Really glad to be here today. Thank you all for joining us. This research plenary session brings together experts on the understanding of the intersections of trauma, chronic stress, stigma, and HIV. With high rates of regularity, we see that trauma often is a precursor to our thoughts, behaviors, changes in the way we act and feel, and can lead to high risk behaviors for HIV. And so today we'll be discussing these interactions, starting with Dr. Sadatman, who will discuss the role that trauma plays in making one predisposed to behaviors that put one at risk for HIV acquisition. Dr. Reeve will then discuss the minority stress model and specifically the role of stigma with persons with HIV and mental health disorders or symptomatology. I'll be talking about mental health trauma and HIV amongst sexual and gender minorities in low and middle income countries. Then Dr. Legrand is going to close out our presentation portion before the questions, talking about evidence-based interventions and what we can do. So where is some of the hope? And then we'll be asking you perhaps those same questions. So just for a little bit of background, Dr. Farrokh Sadatman is an assistant professor at the College of Medicine, Department of Pediatrics and Child Health at Howard University. And she's directed studies that investigate associations between exposure to childhood and community violence on symptoms of depression, drug use, and HIV behaviors. And she's led additional secondary data analyses looking at biomarkers and exposure to violence, including with outcomes of telomere length and DNA analysis. Then hearing from Susan Reeve. Dr. Reeve is a research scholar at the Center for Health Policy and Inequalities Research, Duke University, with her doctoral degree in health policy and administration. She's been the principal investigator of a number of different federally funded projects that look at behavioral health amongst individuals living with HIV and the LGBTQ+ community. She has participated in the design, implementation, and analysis of a dozen other federally funded research projects that address HIV risk reduction and HIV care provision. And she's also a licensed clinical social worker, which is how we met long ago, with a history of working with individuals living with HIV and affected by HIV. Dr. Legrand is a social behavioral scientist with over a decade of post-PhD experience in global health research, associate professor at the Duke Global Health Institute and Center for Health Policy and Inequalities Research. She also serves as the co-director of Duke's Sexual and Gender Minority Health Program. And Dr. Legrand's primary area of research focuses on the overall health and well-being of sexual and gender diverse populations, with a particular interest in understanding the determinants of health that negatively and positively contribute to health outcomes, health behaviors, and access to care. And the goal of this work is to identify culturally relevant strategies at the individual, interpersonal, community, and structural policy levels that can improve the health of sexual and gender diverse populations. She's had many years of working in areas of HIV, both in the United States, particularly in the Deep South, and in other countries. And I am a population health scientist and have been working in the areas of also HIV, substance abuse, mental health, children and trauma. And much of the work that I've done has ended up focusing on trauma, particularly childhood trauma, and what we can do to help intervene. So with that, we will start our panelist presentations. Again, we're going to go through the different panelists. Please put questions. Go ahead and put questions in the chat area that we can be addressing later. We are going to go through each of the 4 presentations and then open it up to a what we think is going to be a fantastic conversation. So, Dr. Sadatman, if you could start.
Yes.
Thank you.
Do you see my?
Yes, we do.
Okay. Thank you so much. I really appreciate it. This is wonderful. So just a little bit about this. You already introduced me, so there is no need for this slide. I tried to do your trick, I couldn't, so I just put the draft there. So this is just a draft of my presentation. There is no conflict of interest. Just a little bit background, and I know probably most of you know all this information, but African American have shorter life expectancy than European American, and then you can see it for females is 3 years, and then for males is 4.5 years. If you live in Washington, DC area, you're probably familiar with this map of the metro and where you are located at the beginning or the end of which line, and especially they talk about the red line. But babies born to mothers in Maryland, Montgomery County, where I live, and Virginia's Arlington and Fairfax County can expect to live 6 to 7 years longer than babies born to mothers in Washington, DC, just a few subway stop away. Also, African American experience societal violence at a higher rate than their European American counterparts. You can see that all these differences between the two groups. I was trying to see what would be the difference between ACEs, adverse childhood experiences that most of us know about, between national, Virginia, our neighboring state, and DC. And then you can see for national is 22.6%. Virginia is 19% and DC almost 25%. So you see even in aggregate, DC has a higher number of adverse childhood experiences among children and youth 0 to 17 years of age. So what do we do with this study that I will tell you a little bit about? So this is an NIH grant that we wanted to look at the exposure to violence and immune function. In this specific presentation, we want to look at community violence, childhood personal violence, what type of violence was experienced and the differences between male and female, consequences of violence on alcohol, drug use, and HIV behaviors. So as I indicated, the ACEs study framework started in the beginning of 1980. You can see this, how adverse childhood experiences impacts every stages of life and every part of your health and mental health system. Then this study that was a national study of about almost 26,000 participants, adverse childhood experiences score indicated that 2 out of 3 experience, and this is national, at least one category of ACEs. If any one ACEs is present, there is at least 87%, at least one other is present, and women are 50% more likely than men to have score of 5 or more. This is just a visual indication of how consequences of lifetime exposure of violence and abuse impacts every part of your body and mind. This is one of my favorite physicians, and she is currently the Surgeon General of California. Dr. Nadine Burke-Harris, who's a pediatrician, said, if you are in a forest and see a bear, a very efficient fight or flight system instantly flood your body with adrenaline and cortisol and shuts off the thinking portion of your brain that would stop to consider other options. This is very helpful if you're in a forest and you need to run away from a bear. The problem is when the bear comes home from the bar every night. Is a really interesting picture how violence and trauma impacts you. So the question that we had we recruited about 600 participants from DC metro area mainly Ward 7 and 8 and 5. And we asked them many questions, especially about childhood violence, exposure to community violence, and many, many other questions. And we, so these are like one question about childhood violence. When you were a child, did anybody hit or attack you without using an object or a weapon? And these were the answers. One question as an example from adult community violence. As an adult, how many times have you yourself actually been threatened with serious physical harm by someone? And these are the answers. So the participants in our study were all African-American from Washington, D.C. area, age 18 to 25, as we call them young adults. The study question included 35-item exposure to personal violence and 35-item on community violence. We had 37-item on alcohol, tobacco, ATOD, alcohol, tobacco, and other drug use, and youth behavioral risk surveillance system. 23 items on knowledge and perception of risk behavior and vulnerability to HIV infection from the health and relationship survey. So we did a factor analysis. I'm not going to go into the detail, but these were the factors that were produced for each one of the outcomes. So exposure to violence, all of that you can see here. What do we know? The prevalence and consequences of children exposure to violence, including experiencing or witnessing physical violence and physical coercion across family and community contexts, has been an area of concern across research disciplines, service providers, and policymakers. Also, in a recent large-scale study population, a nationally representative sample of children and adolescents, 4,549 participants, almost 61% reported at least one direct or witnessed victimization in the past year, 46% experienced a physical assault, 25% reported witness violence, and about 10% reported witnessing family violence. Prevalence rates are even higher when examining experiences of children and adolescents of African American, Latino, and Native American descent as social ecological factors that precipitate violence. And what are those? Social inequality, racism and discrimination, poverty and crime are more common in those environments. A large body of research shows that children exposure to violence can be a significant risk factor for development of emotional and behavioral problems, including internalizing, externalizing, and post-traumatic stress symptoms. Also, drug use, especially using drugs during sexual activity, has been linked to increased risk behavior for contracting HIV. Research with multi-ethnic youth has found that victims of community violence were about 4 times more likely to have had sex without condoms, engaged in sex after drug use, and had group sex than their non-victim peers. So our study, what did we want to find out? We wanted to know, do community violence and childhood exposure to violence contribute to alcohol, tobacco, and alcohol, which we call it ATOD use, and less knowledge of an HIV risk behavior? What are the differences in the strength of association between type of community violence and interpersonal violence and gender? So you can see that even though we had about 600 participants, this specific presentation was the preliminary study of 440 participants that we did, which result is really the same as if we'd have had this for the entire population. So you can see that these are the 8 wards in Washington, D.C. Most of our participants came from this area, specifically Ward 7 and 8, which we call it east of the river. There's many questions that were in this study. What we did a factor analysis, and then we did a regression analysis. Since we had so many questions about those items that I indicated, community violence and personal violence, the best way was to see what are the factors that come together and then do a regression analysis. So what we did, this is a socio-demographic, just to give you a picture, who are the participants. Majority of the participants were between 18 to 21 years of age. About 52% most live in apartment, about 26 or a house that someone else rented or owned. Almost 29% rented their own apartment. 5.7% indicated that they were homeless. Almost all the recruit lived in either, as I indicated, Ward 7 and 8 and 5, and only 7% lived in other wards. 6 in 10 recruits, or 60%, completed high school or GED. 1 in 5 did not finish high school. Over 90% had an income under 30,000 in the past year. Nearly nearly 4 in 5, or 77.5%, had the income under 15,000. So this is just a general picture of the participants. So participants also reported as children, 33% said they saw parents get hit by a partner or a spouse. 42% indicated they saw someone close to them being murdered. Participants also reported as adults, since they turned 18, 66% they indicated they saw people using or selling drugs. 36% indicated they were asked to sell or distribute illegal drugs. So in terms of condom use, 41% said they do not like using it. 34% says it takes the fun out of having sex. 50% said most of my friends use it. 70% said people who use condoms are responsible. 34% said partner thinks you do not trust them if you ask them to use condom. So these are really good ideas. It gives you, if you kind of have this ideas or perception, then what would be your behavior toward HIV risk behaviors? And also they indicated friends have a chance of getting HIV. 46% said that my friend have a chance of getting HIV/AIDS. And they also indicated 62% said I have no chance of getting HIV/AIDS. So these are the major findings of violence and influence on drug use and HIV risk behavior. Our regression analysis indicate that 4 strongest regression model for women were YRBS scales item involving alcohol, tobacco, and other drugs, lifetime alcohol, tobacco use, and age at first alcohol, tobacco use. Alcohol use and marijuana use. Those were for women were the strongest regression model. In the strongest regression model for men were marijuana use and not worrying about HIV, tobacco use and alcohol use. So regression analysis also indicated experiencing, one of the reasons that we did this, it was not just grouping all the violences together, we can say, is either community violence in general or personal violence, but we wanted to know what specific type of violence impacts your behavior. Experiencing gun use or seeing a violent death explained a mean of about 70% of the total variance in both marijuana and alcohol use among men. Direct personal violence explained 70% of the total variance in marijuana use among women, and 42% of alcohol, tobacco, and other drug problem among men. So when we say ATOD problem, the question we're asked whether you have alcohol, tobacco, or drug use problem with in your family, in your job, or in other circumstances. That's what it refers to, ATOD problem. Involvement in drug sales or physical violence had the strongest influence on women. ATOD problem, 82% of the total variance. Lifetime ATOD use, 75%, and feeling unsafe in different situations had a especially strong influence on male lifetime ATOD use. explaining about 80% of the variance. So that's interesting to see how men and women are impacted differently by different kind of violence. Community violence, involvement in drug sales and physical violence, as I indicated. This is for the total, and these are the mean percent of total variance explained. As you can see, the problem with alcohol, tobacco, and other drugs are 82% of the variance. Lifetime HEOD is 75%, and not worrying about HIV/AIDS is about 66% of the variance. Also, regression analysis, besides explaining the alcohol, tobacco, and other drug factors among women, it also influenced women's knowledge of HIV risk health behavior. Among women, exposure to the direct physical violence explained about 66% of the total variance in model for behavior that obviates the need to worry about HIV. Exposure to gun use or selling violent death explained about 77% of the total variance explained in women's attitude toward condom practices. Also, regression analysis indicated, in contrast, among men, exposure to childhood sexual abuse explained about 37% of the total variance in worrying about contracting HIV/AIDS. This is really important. Sexual abuse among men showed up in our analysis. It did not show up among women. Feeling unsafe in different situations was a far stronger factor for men, explaining a mean of almost 80% of the total variance across the regression, compared to only 4% for female. So as I indicated, another differences between male and female. This is just another representation of type of violence impacted behavior among male and female. As I indicated, I already explained that this is just a graph. Major finding about males also I indicated. These are just a graph for visual presentation to get a better idea. I just wanted to finish with one or two quote. Alice Miller was one of the leading psychiatrists that passed away several years ago, and she did a lot of work on trauma among children. And these were one of the quotes I found that really made sense to me. Those children who are beaten will in turn give beating. Those who are intimidated will be intimidating. Those who are humiliated will impose humiliation. And those whose souls are murdered will murder. Another quote by her that the reason why parents mistreat their children has less to do with their character and temperament than with the fact that they were mistreated themselves and were not permitted to defend themselves. So what is the bigger picture, and what are the reason learning from this? We need to increase how various type of violence exposure affect men and women differently. Our awareness increases about the long-term effect of childhood exposure to violence. Consideration should be given to establish trauma-informed care into social support services for youth. Substance use disorder should be addressed as a trauma-informed, from a trauma-informed perspective. These are my co-authors and co-workers. This is the information about the grant from the NIH. And thank you so much.
Thank you so much. That was wonderful. And we'll move on to Dr. Reeve. Super, we can see your screen. And you're muted. Go ahead.
I got it. Okay. Good morning, everyone. Thank you so much for joining us this morning, and I'm glad to have the privilege to hear that previous presentation. It frames us nicely into some of the topics we're going to be discussing today. So as Kate mentioned, I'm Susan Reeve with the Center for Health Policy and Inequalities Research at Duke University. For over 20 years, our center has been involved in research and demonstration projects related to HIV, mental health, substance use, and of course, HIV-related stigma. I became acutely aware of HIV stigma even before that, when I was working as a social worker with people living with HIV and really witnessed the high levels of stigma and discrimination and their negative effects on people living with HIV. Of course, that was a long time ago in the early and mid 90s. And since that time, we have there's been incredible advancements in the treatment of HIV. However, unfortunately, there haven't been parallel grand improvement in HIV-related stigma. We still see stigma being pervasive and having really potentially damaging effects on people who are experiencing it. So I have the privilege today of talking about presenting some of the seminal work on HIV-related stigma, its effects, minority stress, and some of the ways to start mitigating these stigma effects. So, okay. So I do want to start with a definition of stigma. I think being this is a stigma conference, you may hear maybe a dozen more definitions of stigma, but I think it's a good place to start in terms of just framing our discussion. This is a definition that I particularly like from your dictionary. I've seen it multiple places. It says that stigma is something that detracts from the character or reputation of a person or group. It's a mark of disgrace or reproach. And that sounds really terrible. But I think it's a good reminder for us not to underestimate the potential effects of stigma and of discrimination, be that manifesting as physical violence, as we heard about in the earlier presentation, and also in meeting basic needs for housing and unemployment, and to, of course, verbal and emotional abuse, which can be as damaging as any other the types of negative experiences. I also like this quote from Les Mis. I think it helps kind of depict the experiences of people living with HIV and experiencing stigma. It says, whether true or false, what is said about men often has as much influence on their lives and particularly on their destinies as what they do. And I think that really is compelling representation of what can happen in HIV stigma. It can really affect the course of somebody's lives and their decisions. But in a hopeful manner, we can say it's also a place of potential intervention to mitigate this stigma effects. So here are some of the stigmas that may be experienced by people living with HIV. And I have in the references section, there is lots of literature cited on all of these different types of concepts that I'll be presenting. So I think that will be available. The slides will be available to everyone. So of course, there's a stigma associated with HIV diagnosis, which is often influenced by misinformation, myth, and cultural climate. Most of my work in HIV has centered around the Deep South, where there's been a disproportionate effect of HIV, and certainly the cultural climate, the cultural conservatism affects stigma in this region. There's also mental health related stigma that may be mental health concerns that occurred prior to diagnosis or as a result of diagnosis. But we know in our culture, there's a great deal of stigma around mental health and around mental health treatment. There's also substance use related stigma. In terms of poverty, we know there's a high prevalence of poverty among people living with HIV, and there may be stigma around poverty. And then minority stress and stigma be a topic we'll be talking more about throughout this presentation, and there's a growing body of literature around the negative effects of this minority stress, which is just often associated with being part of a group that's been oppressed or or discriminated against. And for people living with HIV, that often is in the form of racial or ethnicity related stigma or LGBTQ related stigma. And so we've seen this growing, oh my goodness. Okay, I can't read my own slides. Okay. I had to get all the people out from my screen. So there's been this growing body of literature around the minority stress model. And the minority stress model, read this quickly, posits that within the social structure of particular culture or society, certain oppressed groups experience greater incidence of minority stress based on their race, their gender, in the form of prejudice and discrimination. As a result, these experiences, members of oppressed communities experience greater negative health outcomes in majority group communities, which leads to large health disparities. And of course, we're all aware of the health disparities that exist in many diseases, not just HIV. So how does this minority stress influence health outcomes? Well, the minority stress model, and this is some of the quotes in the model I'm going to be presenting are from Meyer and colleagues from 2003, and that's also in the reference list. But there's two really important types of stressors according to this model. And the first is the distal stressor, which these are the external stressors that can happen from institutional or individual stigma and discrimination. And then the proximal stressors, which are actually internalization of these distal negative experiences. And they can lead to self-stigma, particularly when they take on a psychological importance to the individual. I think it's really important to say that we don't want to be sounding like we're blaming people who are experiencing a stigma for internalizing it or creating this sort of self-stigma, because that is really a natural kind of human response to experiencing these really negative effects. But it is a place of potential intervention, which we'll be talking about more in this presentation. So minority stress, according to Meyer and colleagues, has been described as a continuum from these distal stressors, which are typically the objective events and conditions, to these proximal processes, which are by definition more subjective because they rely on individual perceptions and appraisals. So here's the minority stress model by Meyer. And you can see, hopefully you can see it okay, but it can start with this minority stress, whether it's sexual orientation or race, ethnicity, and that can put people at greater risk for these distal and proximal stressors, which in turn, along with sort of coping and having social support or not, can lead to these potential negative mental health and medical outcomes. So here are some conditions that have been gaining some evidence around the effects of minority stress on these outcomes. And this is in particular for race, ethnicity, although there's certainly a growing body of literature around the negative effects of LGBTQ stress as well. But here are some of the potential negative effects that have been documented, such as diabetes, hypertension, cardiovascular disease, mental health conditions such as depression and anxiety. So how do these work from a physiologic perspective? I think this is a really cool representation from, I can't see it on my slide now. It's in the references, but they had, this is a review on the effects of minority stress on biologic conditions. So it starts with the minority stress experiences and internalization, and it moves actually to these mechanisms of epigenetic changes and at these allostatic overload and dysregulations, which we won't be discussing in this presentation because I'm not certainly an expert in these, but certainly more familiar with their effects. From inflammation to metabolic functioning and endocrine and hormonal regulation, which in turn lead to these really negative outcomes in terms of blood pressure and heart disease, cancer, diabetes. Just turning a little bit to the HIV stigma literature, there's a really large and consistent body of literature showing that HIV-related stigma contributes to lower quality of life and poor health outcomes, such as higher viral load, health behaviors such as adherence to medications and emotional health, and that these stigmas are very interconnected. And that can be the types of stigma are interconnected. External stigma, which is similar to what I mentioned earlier as the distal stigmas, is very related to internal stigma, which of course is the same as the proximal stressors I mentioned earlier. Those are related, as is anticipated stigma, another form that just refers to people's anticipated concerns about it, what would happen if their HIV status were disclosed. And then this HIV stigma is highly connected with other types of stigma, the mental health and substance use and LGBTQ related stress and stigma. So because there's such an interconnection between these levels of stigma, there's emerging literature on how we need to take a intersectional lens to study and address these intersectioning stigmas. And there's some work by Bolig, 2012, and we're quoting some of that, and talks about intersectionality is that theoretical framework for understanding how these social identities interact, and that the intersectional stigmas can often have greater effects than one type of stigma alone, but they can't just be taken additively. You can't say, oh, well, here's the stigma that I had experienced for being female, and here it is for being HIV positive, that they really intersect in their effect. Bolig says the most elemental tenet of intersectionality is the notion that social categories are not independent and unidimensional, but rather multiple and interdependent. So it's important for us to develop instruments and methods to better measure and describe how this intersectional stigmas can have an impact and how to intervene. And there have been, there's an article by Turton and colleagues in the reference section that talks about methods that can be used to measure intersectional stigma. So I stole this slide from another place. I really liked it. It talks about the way we imagine, it's quote, saying the way we imagine discrimination is more complicated for people who are subjected to multiple forms of exclusion. It's not simply that there's a race problem here or a gender problem there. That framework erases what happens to people who are subject to all of these things. It's a quote from Kimberly Crenshaw at the Columbia Law School. So what do we do about these this stigma and effects? There's different types of interventions ranging from more community level to more individual level. I'm going to be talking more about individual level interventions in this presentation, but there is, for those of you here for the whole convention or workshop, there is one on the last day, I believe, from our colleagues at Gilead Compass. They'll be talking about some of the really cool interventions they're doing at a community level. But in terms of an individual level interventions, there's more literature, and that literature is saying that there's different ways to really mitigate stigma effects. And these can include this building resilience, enhancing social support, addressing mental health and trauma, and increasing coping skills. And I put them all together on this little diamond to show that they're very interconnected. So we don't have to have 4 different interventions. Often an intervention to influence one area will improve the other areas. For building resilience, there's a neat link on this slide to an article by Deepa Rao about some of the ways that have been found to be effective to build resilience, particularly among African-American women. Building trust and self-esteem, spirituality, and of course, social support is key. because we know social support has been consistently associated with HIV-related stigma. We did a study recently that was on HIV-related stigma in the Deep South and found that for people experiencing recent verbal negative HIV-related stigma, that in events that those that had higher levels of social support had less internalization of the stigma that they experienced. So showing potential protective effect of social support. There's been other subsequent articles and research that has also shown similar findings. And then there's emerging interventions that enhance social support. They've shown some effectiveness in reducing HIV-related stigma. One of those is also by Deepa Rao that I mentioned. It's called the Unity Workshop, and it's been used for African-American women. We adapted it and used it among men as well, and saw some effects on reducing stigma and increasing social support and coping skills. So then we already heard about trauma and the connection with mental health, and that's a really critical area to intervene. And research has shown some effects of participating in interventions to address mental health and substance use that can reduce stigma. I think Sarah will be talking about our CREW study and that effects a little bit later. And we also know that evidence-based interventions such as EMDR, trauma-focused cognitive behavioral therapy, CBT, have been shown to improve mental health symptoms and reduce PTSD effects. And so those are important things to have in our toolkit, but we do know that more research is needed to look at the effectiveness of these interventions among minority populations and see what adaptations need to be made. There is one article in the reference list of a recent study on adapting trauma focused CBT among minority women that showed some real promise. So just in conclusion, the HIV-related stigma we know is prevalent, associated with their negative outcomes in certain cases. We know that intersectional stigmas, including stigmas associated with minority status, are common and often interrelated and interdependent with HIV-related stigma, and that we need to take this intersectional approach to examining HIV-related stigma. And their multifaceted approaches are needed to attenuating stigma, including building resilience, addressing trauma, and enhancing social support and coping. I want to see if I can real quick show the poll results, because we asked what y'all were doing. Excuse my Southern accent with my y'all. Hopefully you can see this, that we had 139 people answer the poll about interventions that you're up to at your organizations. And we see half are building resilience. We have nearly 70% enhancing social support, got 47% addressing trauma, and 50% enhancing coping skills. So that is wonderful to see. And we'll be looking in the chat to see some of the other things that you're doing that weren't listed here. I did see one on increasing self-love. So that was wonderful. So I'm going to end there and turn it over to Kate to talk more about international issues.
Wonderful. Thank you, Susan. And we see some good questions coming in the chat, and we will be getting to them at the end after the next two presentations. So I'm just going to start off kind of talking about sexual and gender minorities in low and middle income countries. And specifically not quite taking the HIV lens. I think one of the things that we realize, particularly those of us who have been working in the HIV field in some capacity over the last few decades, is that there's a much broader lens to take with sexual and gender minorities broadly. I'm using the term sexual and gender minority as it is the term that's used by the National Institutes of Health now. And we can discuss its use later, but it is meant to be inclusive of all LGBTQIA+ individuals. So a little bit on research background. Sexual and gender minorities in all regions of the world experience stigma, discrimination, violence, victimization. We've known this anecdotally, but we really have not been able to quantify the degree of stigma, discrimination, violence, etc. Or kind of the well-being. We really have not looked at the well-being of sexual and gender minorities broadly. But we do know from studies mostly in wealthy nations or very small studies from low and middle income countries that we've got the different terms here, that lesbian, gay, bisexual individuals have 2 times the risk of suicide attempts, 1.5 greater lifetime or past 12-month risk of depression, anxiety. They have higher rates of substance use and dependence. And again, looking across different identity groups, bisexual individuals who are often just neglected in all literature and research, also are experiencing much higher rates of lifetime depression and anxiety than heterosexual individuals. And we see amongst young adults very high rates, so 52% of a very large sample of young people showed that they had depression and anxiety, compared to 25%, 14% of cisgender males, and 27, 30% of cisgender females. So again, as we've gone into this work, there's little work across different sexual and gender minority identity groups, and little to no work in low-income countries. So what we also know is that policies, this is a map from ILGA. It's the international, it was named long ago, so International Lesbian Gay Association. And they've been compiling some fantastic data from around the world where we look at different kinds of policies for sexual and gender minorities. And when we look from a policy lens, the dark blue, and I don't need to take all of this in, but just as a visual, dark blue is where there are broad protections. And then going to light blue, there's employment protections, the white or lightest blue, unlimited or uneven protections, to kind of our red, dark areas where you can be killed for being sexual and gender minority, or in some places even talking about sexual and gender minorities. And we believe that policies are both reflective of a population and can also improve populations. We've seen in the United States, because with gay marriage, as it was implemented across different states, we were able to follow the implementation and see how mental health improved amongst sexual and gender minorities when gay marriage, even if amongst people who didn't want to get married, weren't in relationships, but that just by the policy of having gay marriage, mental health improved. And in states where there are detrimental policies, we see immediate declines in mental health and well-being. And we're seeing all of this right now, of course, with the different transgender bills that are being proposed in states around this country. So we decided to do a pilot study. I've been lived in the DRC, in Brazil, in China for almost a decade, and have been working around the globe since about 2001, so for a long time. And so we decided to ask our partners, not partners who are in HIV clinics, but partners who have been working with us on other interventions, looking at kids who've been orphaned or permanently separated. So can you find sexual or gender minorities across different gender categories and attraction? And we use attraction rather than as sexuality, because we know that in many places where there are high rates of stigma, particularly, and there aren't networks of individuals, there may not be sexual activity that's going on. So we talk about women attracted to women, men attracted to men, bi-attracted individuals, and separating that cleanly from gender identity, which is cisgender, transgender, gender nonconforming, and using appropriate terms for those in the different countries. And what we found in our pilot study that took place in Cambodia, Vietnam, Kenya, Brazil, El Salvador, was that one, we were able to find people very quickly. Even in our more rural sites, such as in Kenya and in Cambodia, we are not in the major cities there. We exceeded their sample size goals and were able to find transgender men, women attracted to women, men attracted to men, transgender women. And people wanted to talk, and we're really surprised that anyone cared for them, or that someone was asking questions that were beyond HIV and beyond, and not asking about sexual activity. And in each of the countries, there's at least one focus group, someone who said, thank you for not treating us like HIV vectors, and seeing us as whole people. So what we found in the pilot is very much in line with what we've seen in high-income countries. So, this idea that being a sexual and gender minority is something that is the privilege of people in wealthy nations, and something that we do, that we create because we want to. We found that 50% of the total sample was reporting suicidal ideation. 30% had attempted suicide in their lifetime. 20% had made a suicide plan. 15 had attempted suicide in the last 12 months. And people reported that they were going to try again and again. And this is people who have survived. Going back to the map, you may remember or know that in Brazil, we have the highest count of transgender women who are murdered each year. And we know that count is real and terrible. And it seems one of the things that, because of the positive policies in Brazil, they're actually able to count all the people who are killed. And there's a very large kind of grassroots networks that are documenting what's happening. This is not true in Kenya. As one of our sites, for example, there's no one counting the deaths. There are no newspaper reports, and some are by police themselves. Transgender men had particularly high proportions of suicide plans and attempts. 93% of sexual and gender minorities, again, across minority status, had experienced at least one of the types of discrimination past 12 months. We'll go over some of those types of discrimination later that you'll see. And 50% had experienced more than 4. So that's like being kicked out of your house, losing a job, being beaten up because of your identity, things like that. A third in every of the minority groups, so including women attracted to women, bi-attracted men, at least a third had been physically assaulted in the past 12 months. And they're very, is high rates, and just the findings that we found just indicate the need for research that leads to interventions, which is what we really struggle for. So in the research we do, where can we intervene at the policy level, at the individual level, at the community level, with providers? This graph, I'm going to take you through a few graphs, and we're going to go pretty quickly. Don't worry about absorbing all the information here. What I want you to get is more just a general picture of what people are experiencing. So This slide, we're looking at major depressive disorder. So we did screeners, of course. We weren't doing clinical diagnoses. Generalized anxiety disorder, post-traumatic stress disorder, and suicidal ideation. So the dark blue is the major depressive disorder, and then going down the line here. So we see Cambodia, Vietnam, El Salvador, Brazil, and Kenya. Kenya is missing the PTSD bar only because we had some measurement difficulties there. That was a miscommunication. And we're actually going back into that data, and we'll have that later. But you can see in the country where the policies are most draconian of our sample is also where we've got every one of our respondents reported, which would have screened in for major depressive disorder, generalized anxiety disorder at 90%, and suicidal ideation at almost 80%. But that's not to say that over in Cambodia, with 40% of our respondents reporting suicidal ideation, or Vietnam, 37%, we would say the stigma and the life experiences that are leading to this are quite harsh. So here we've just broken it down in a couple of different ways. And the important thing here, the kind of overarching take on these graphs, again, not to focus in on each proportion here, is that across the different groups, whether it's transgender women, women attracted to women, transgender men, men attracted to men, and bi-attracted, that's what our acronyms are down here. Everyone is experiencing high levels of uncomfortable mental health symptomatology. Here we have the same for PTSD and suicidal ideation. Again, transgender women, women attracted to women, transgender men, men attracted to men, and bi-attracted individuals. And so when we look at, I'm just having to move things on my screen. I'm not going to read all of the text. What we have when we did this pilot study, again, the numbers, well larger than what we our goal. It's still a pilot study with relatively small numbers from each country, and so I'm just going to read a couple of the qualitative quotes where we did focus groups and some individual interviews. Just 4 of these, and then we'll wrap up with the study that we were funded to do based off the pilot work. So being denied a place to live or lost a place to live, you can see that in Cambodia, 17%, Vietnam, 34%, Kenya, 72% had lost a place to live. But again, 17% is bad enough. And again, across the different gender and attraction groups, so transgender women, transgender men, women attracted to women, bi-attracted. So I won't go through each of those for each of the slides. I will say, so we have the transgender woman from El Salvador. She says, then I received the rejection at age 14. They threw me out of the house and I had to stay alone. I had no relatives, no friends, no economic stability, social or moral support that leads to the only option that you can find when you do not have what it is to eat. It's the next truth, engaging in sex work. Here I'd have, you've been denied a job or lost a job. Again, you can look at the numbers on the right side of the screen, and I'll read. Vietnam, a transgender male. In some companies, they put up signs that say, we don't accept women who are like men, or men who are like women. In Kenya, woman attracted to women. Women says, one might be lucky to get a job from an NGO dealing with LGBTQ plus people. However, NGOs are few, and most of the time, they need people with specialized qualifications. One of the things that is very apparent in a number of the countries, is and including in the US, it's so hard to even make it through middle school or high school as sexual and gender minority. because of discrimination that happens in the school setting and with peers, with teachers. Have you been treated poorly, made to feel inferior when receiving healthcare? Kenya, transgender woman. I was emotionally disturbed when I went to get help from the hospital. I was victimized and doctors called one another to see a gay who's been raped instead of giving me the medical attention I needed. It was a horrifying situation. So I had to leave the hospital without getting treatment. And we heard that also across different countries, people not able to get even basic care. So needing to go in for, if we look at the minority stress model, people who are experiencing the kinds of things that are being expressed here are going to have higher rates of not just mental health symptomatology, but cancer and diabetes and blood pressure and heart disease. And so there's an even greater need just for healthcare that's not related to STIs, and yet people are afraid to go. We heard in El Salvador, people going in for, women going in for gynecological exams and actually being physically abused by the provider while there because of their sexual orientation identity. Experienced physical assault, been beaten up. So similar to our first presenter. Transgender woman in Brazil, I was raped so many times, you know, by family members, clients, partners, and police. It's not only rape, it's like everyone feels like they can touch your body without consent. I had a guy touching my butt when I was walking in the street with a friend and inside the bus or everywhere. It's crazy. Even if you are not a prostitute or when you're not working on the street, it seems like we're always for sale. You know what I mean? In Kenya, women attracted to women. That's why we are arrested and treated brutally most of the time. It's not allowed. That's why the police arrest and extort money from us. We are arrested all the time because we are criminals polluting the environment. In Kenya, they also said quite strongly that the form of Christianity that is there is quite judgmental, and for the most part. Not everyone, but and respondents said that pastors would say that as sexual and gender minorities, not using that term, that they are equivalent to devils, evil that's put on earth to tempt good people and to given a chance, would I not be a sexual and gender minority? Would I accept? And here's where you see this interesting, you know, Brazil, where in just all of this violence is happening, is also a place where people were most likely to say no. I would claim my identity. Other places like Vietnam, Cambodia, Vietnam, transgender women. Honestly, all transgender people have psychological problems. The first thing is that our appearance has already made people prejudiced, people discriminate against us. So of course that makes us feel uncomfortable. Everyone stares at us when we go out in the street, for example, and also in the workplace, schools, and especially in relationships. 10 out of 100,000 people are able to find happiness or a husband or able to have a happy family. So it's easy to be really sad and melancholy. Kenya, the rest of society sometimes treats us very badly. I've attempted suicide several times because of the loneliness. So from this work, we wrote an NIH proposal and selected 3 of the sites in Vietnam, Kenya, and Brazil to do a large 5-year study, 3 waves of data collection, really looking at mental health and well-being and in relation to experiences that people have, and focusing on resilience too. What are people doing to survive? What can we do to help each other? And the goal of this research is to identify ways that we can start intervening. In this case, with mental health services, and how can we build those? And the team that we have has some experience in implementing successfully, working with lay providers, trauma-focused cognitive behavioral therapy, and other what we call manualized interventions, mental health interventions that could be delivered by sexual and gender minorities. So we could be creating a workforce while also creating a sustainable option. So I will end there and go on to Dr. Legrand, and again, we'll get questions after Dr. Legrand's talk. Thank you so much. Take it away, Sarah.
I am working on it.
Awesome.
All right. All right, can you see my slides? Okay.
Yeah, yes, they're small on the corner of your screen. So we also
hold on, let me try that again. Apologies. This should be good. There we go.
Yeah, beautiful.
All right. Okay, so I have somewhat of a tall, sorry. Oh, never mind. Adapt. Okay, a tall task of talking a little bit about what we can do to combat stigma. And just to kind of start off, there is really fairly limited evidence or rigorous evidence about the effectiveness, efficacy of stigma reduction interventions due to a lot of different reasons, such as research design, so in some cases cross-sectional studies, in some cases a lack of a control group. In many cases we need kind of longitudinal studies so that we can not only see if stigma is reduced, but also determine if it has implications for health outcomes. So, but that's not to say that there's not evidence that there are stigma reduction interventions that do work. It's just that we don't have a super clear picture of exactly what the best evidence-based practices are. All right, so I'm just going to start off. So I'm going to talk about a few key ingredients, through all the work that's been done over the years. I think we are really honing in on some key ingredients for developing effective stigma reduction interventions. And then I'm going to talk about 3 stigma reduction related interventions that that our teams are working on or have worked on. So the first key ingredient is a theoretical framework, and that is really to guide intervention development, measurement, research, and policy. And this is the Health Stigma and Discrimination framework. And this framework is actually not specific to any particular health condition, but rather is intended to be cross-cutting, which has tremendous benefits in that, of course, it will, would have to be adapted somewhat depending on the condition, but it's really an effort to have an opportunity to look across health conditions, recognizing that there are often comorbid conditions. So this really does kind of bring those together. So I just kind of described this a little bit briefly. First, just a note at the bottom. You notice that this is all kind of framed in this socio-ecological perspective, in that we do need to consider stigma reduction in the context of the individual level, the interpersonal level, the organizational level, community level, and public policy level. So I think always thinking about the different levels and how it's important to intervene at multiple levels is important. And so at the next kind of level here, we have both drivers and facilitators of stigma marking. And drivers are factors that are negative. So fear of infection, fear of social economic ramifications, social judgment, stereotypes, prejudice. And then the facilitators could be either positive or negative. So cultural norms, social and gender norms, health policy, those can be, again, either positive or negative influences. But if these factors do kind of coalesce to mark a person as stigmatized. We have kind of these two elements here too. First being the health or multiple health condition related stigma or stigmas. And I also like this framework because it recognizes the importance of intersecting stigmas, as both Susan and Kate alluded to the importance of this. And so, you know, if we have this health condition stigma, you know, combined with other marginalized identities such as race, gender, sexual orientation, gender identity, occupation, then we really do have these intersecting stigmas that, you know, as Susan mentioned, we really have to start thinking about ways to address these intersecting stigmas and not just the health related stigmas. So these then move into the manifestations of stigma, and stigma experiences are those that are experienced by the person who is stigmatized. So that can be, you know, experienced stigma and discrimination, internalized stigma, perceived, anticipated, and secondary stigma. And I think Susan touched on what, you know, kind of each of those are, except maybe secondary stigma, and that really refers to the stigma experienced by people who are close to the stigmatized person. So perhaps family members, it could even be healthcare providers. And then stigma practices. So, you know, the stereotypes and prejudice and behaviors and discriminatory attitudes that occur towards people who are being stigmatized. And then this then leads to, you know, for affected populations, it can influence access to justice, right to health, uptake of testing, adherence to treatment, resilience and advocacy. And in terms of resilience and advocacy, those can actually be, you know, the result of these stigmatizing experiences is that, you know, kind of this, oh my gosh, I'm losing my words. Anyway, I'll stop there. But can really be these kind of protective and efforts to combat experiences of stigma. And in terms of organizations and institutions, these can then influence laws and policies, the media, law enforcement practices, and social protections. And then these then have an influence on health and social impacts, including incidence, morbidity, mortality, quality of life, and social inclusion. So next is, you know, so we have a framework, and so then it's really important to intervene at critical points within the framework. So first, you know, if at all possible, we want to interrupt the stigma process by addressing those drivers and making those facilitators more positive and more protective. Then we can kind of prevent people from being marked or stigmatized. However, you know, if it moves on to these manifestations, then we want to minimize the harm of the stigma experiences and also work to alter the attitudes and behaviors to change stigma practices. And then we want to include strategies that are likely to increase intervention effectiveness. So this is actually hugely important, is including multiple stigma reduction approaches. Some of these depend on who the source of intervention is. But, you know, there are multiple types, and I wouldn't say this is necessarily a comprehensive list of approaches, but, you know, information-based, skills building, counseling and social support for those who have experiences or are experiencing stigma, contact and partnership with effective interventions. This could be really powerful, and this will, I'll come back to when I talk about involve those affected, but this is essentially having folks who are stigmatized, who have all of the support they need to do this, but to actually be a part of interventions, because it helps to kind of humanize the experiences that a person who is experiencing these stigmas is going through, and in an attempt to really develop empathy among those who may not have previously had it. Of course, structural interventions, and then some biomedical interventions as well, particularly in the context of HIV, may also have the potential to reduce HIV stigma. For example, you know, antiretroviral therapy, PrEP, etc. Then of critical importance is really intervening at multiple social ecological levels. This has been, I think, found consistently across multiple reviews and studies that it really, we really must intervene at multiple levels in order to make progress in reducing stigma. So at the individual or interpersonal level, interpersonal, organizational, institutional, and public policy levels. Also, as you know, again, as Susan mentioned, addressing intersectional stigmas and recognizing that as humans, we're not just one thing. We're not just a health condition. We're not just our education or our race or ethnicity or our sexual orientation or gender identity, but that all of these things, you know, kind of coalesce to create who we are and what we experience, and also affects our positionality. And we also want to target a range of actors. Of course, affected individuals, for those who experience internalized stigma or anticipated stigma, families and peers of affected individuals, community members and leaders, popular opinion leaders and influencers can have a strong impact by using their platforms, along with community leaders, organizations and policymakers. And also critically important to involve those affected. So nothing about us without us. So I think including those affected in, you know, the design of a stigma reduction intervention, you know, all the way through to, you know, interpreting results. Okay. So also involving those affected in the intervention, as I mentioned before, as I talked about, kind of the contact approach. Okay. So some examples of our stigma-related work. I'm going to go a little bit quickly here because we don't have much time. The first I wanted to talk about is our intervention, Carolina Alcohol and Drug Resources, or CADRE. This is a SAMHSA-funded study. It was a 5-year study that was a holistic substance use and mental health treatment program for people living with HIV in the Deep South. And it was a harm reduction program. It included individual and group counseling, case coordination, and peer navigation services. Individual counseling was provided weekly and used, you know, evidence-based modalities. And we had a kind of a modified intensive outpatient model for group counseling, and these occurred twice a week. The first half was dedicated to psychoeducation topics. And the second was an opportunity for group sharing with guidance from the counselor. So in CADRE, we had two, and I do just want to highlight that this is Richard, our peer, who is absolutely incredible, is currently working with us on a kind of a subsequent program that has followed CADRE. Incredible peer, incredibly powerful, and an important, critically important to the success of our programs. So we had 241 participants, and I do just want to highlight the intersecting identities of our individuals. So they were people living with HIV. The majority were Black. Many had disabilities. They were typically skewed in an older age range. I think the average age was 49, but up to 67. We did have individuals who were sexual minorities or gender minorities. And high proportion of substance use and mental health disorders. So with this program, which provided 1 year of services, we did see a significant decrease in substance use, mental health symptoms, internalized HIV stigma, and an increase in overall social support over time. And so what we know is that, for prior studies, reductions in internalized stigma and improvements in overall social support, as well as the outcomes related to mental health and substance use, improve outcomes along the HIV continuum. And also we found the decrease in internalized HIV stigma was associated with reduced depressive symptomology over time. And, so by decreasing internalized HIV stigma, I mean, we know these stigma and depressive symptomology are strongly related, but by reducing this internalized stigma, we believe that helped to also reduce depressive symptomology. So next, I want to talk a bit about resist, intervene, support, and empower, or RISE. And this actually is a bit related to some of the comments that Kate made. So as Kate pointed out, we have these very progressive laws around designed to protect gender diverse people in Brazil. However, transgender women experience more stigma, discrimination, and physical and sexual violence than the general population or sexual minority individuals. So there's a little bit of this paradox. And these experiences contribute to a wide range of mental health disorders. And in a survey that was conducted by our team in Brazil, you can see here that the rates of violence, major depressive disorder, attempted suicide were incredibly high. So this is a study that is currently getting underway, but I'm excited to report a little bit about what it will do. But I did just want to highlight, this is my public service announcement for today, that Saturday is actually International Transgender Day of Remembrance. And this also, I'm not going to spend too much time here because Kate also talked a bit about this. We know that the murders of trans folks is drastically underreported. But in the last year, there were 375 reported murders, and Brazil accounted for most at 125. Again, some of that is because Brazil does have the capacity to track and report these, but still, it's alarming. So RISE is a community-engaged approach to adapt an existing app for LGBTQ individuals in Brazil, specifically for transgender women. And what RISE will do is use crowdsourcing to populate maps that help identify risky and safe areas in Rio de Janeiro and show locations of trans appropriate services. Users will be encouraged to report their experiences of violence. And if they report violence, then they will be prompted to access crisis support from trained community health workers or at locations that are safe and equipped to provide appropriate care. They'll also be prompted regularly to complete mental health screenings, and those screening positive for a mental health concern will be referred to trans appropriate treatment services. And lastly, we will incorporate some gamification elements to encourage app engagement. And so I just wanted to talk a little bit about how we think that RISE will actually combat stigma. So in terms of gender minority stigma, discrimination, and violence, we think by increasing self-efficacy to avoid risky areas and high levels of reported violence against transgender women, and increasing self-efficacy to cope with negative experiences, and lastly, by building an online community of transgender women. And RISE will combat stigma associated with mental health disorders and treatment by increasing self-regulation through completion of mental health screenings, tracking screening results, and accessing treatment when needed. So I'm going to skip the next one and just go to a few, this actually will be my last. I have some research recommendations, but I'm going to stop here. This is the positive bit here, right? There are some really exciting things going on in the space of stigma reduction. So my question is Lil Nas X a stigma reduction influencer? So you can see at the VMAs, he was working to reduce stigma around LGBTQ Americans, and also the stigma that fuels HIV, particularly in the South where he's from. Also, there are many other influencers that can use and are beginning to use their platforms to do similar work. I will stop there. Much more to say, but happy to answer any questions.
Thank you for your presentations. I'm going to, Dr. LeGrand and I will kind of tag team on asking questions that you presented in the chat. And I'll start with one from Dominique. Could you provide examples of community level interventions that can combat stigma? I'd actually say that we've seen stigma combated through policy change and through discussions. We actually, going back to what I was talking about with Kenya, we've worked with pastors as a way of reducing stigma. So those are just a couple of examples. Others on the panel who'd like to respond to that?
I can add to that too. Sorry, my video's not on. So I think some not necessarily concrete examples like that, but and sorry, I'm looking at my other screen. My other monitor isn't working at the moment, but I think that there's kind of a hierarchy of interventions at the community level that can be used. So I mean, the first is just kind of information, knowledge about conditions and stigma manifestations and its effect on health. A lot of stigma reduction interventions focus on information, and truly that's not enough, right? So I think also kind of skills building, so helping people gain the skills they need to interact with a stigmatized person. And I think also, again, kind of that contact and partnership. So bringing members of a stigmatized group to have discussions to develop empathy and humanize, and also policies, which can be difficult, but necessary to change policies to help combat stigma at the community level.
And Dr. Sedetman, there was a question about whether there were gender differences in the kinds of discrimination and stigma, and I think you addressed that somewhat in your talk, and whether it's kind of implies it better or worse for men or women. It looked like it was there are differences in what people experience. I don't know.
So we did not specifically look at stigma. We looked at the gender differences in terms of HIV risk behavior and drug use that we know they come together. So in terms of stigma, there was not questions about stigma, but I can imagine there are gender differences. And as we know from the presentation I gave and our data, like the men who were exposed to childhood sexual abuse, they had different outcomes in terms of whether it was alcohol, drug use, or whether or not using condom, or they did not believe in that. And the women were also exposed, who were exposed to direct violence. So that was the difference between male and female. And then also another one was the men who did not feel safe in different situations. They had more vulnerability than other people. So that was the result. We did not look at stigma specifically.
Yeah, I think one of the things that we've kind of, as we're moving forward in understanding the impact of trauma and also chaotic, unpredictable living situations, is that there is multiplicative effect. So there's another question about, do you think it's harder the longer someone's been, I'm talking about stigma, but it could be different experiences that we have, is it harder to overcome the longer you've been experienced stigma or violence? And what we find is that it is harder as different categories of violence or stigma that adds on, and we do see that the worse mental health outcomes are over time, and it is harder to combat them.
And even with regard to some other analysis that we have done in terms of vulnerability to, even as we're talking about the age group that we had our data, 18 to 25, you do not think they will be kind of a candidate for health outcomes like poor sleep, mental health, or even shorter telomere length, DNA methylation issues and all of that, and heart issues, that you know that this is an age group that we studied, that we're hoping by showing how you prevent from the early age, not just young adult, even before that, but the manifestation comes as early as age 18 to 25 when we're looking at violence and different health outcome and HIV risk behaviors.
And if we have time for one more question, there's one for you, Professor Wetton. So the question we must ask is, where is the data of the past to compare to the present? Is it moral values, integrity, or discrimination and or hatred?
Yeah, and that's an excellent question. And we can't go into the past and ask the same questions again. So what we have is kind of historical evidence, anecdotal evidence. We know that there are in many cultures and communities around the world where sexual and gender minorities were thought of in a positive light. In some communities and cultures, even having closer connection with deities and people who are thought to best be able to take care of children in some cultures, that would have a different impact on mental health and well-being. And we see from our data, and the reason we're choosing very distinct culturally, religiously, kind of in all ways politically countries, is so that we can start looking at that. And we do see that there is more acceptance in those countries where, for example, Buddhism is the prominent religion. And so I talk about that as it's going back in time, but also we can look across cultures today and look across communities today and extrapolate from that what's happening. And in different places, it's different things. Undoubtedly in Kenya, we'll see, I won't say undoubtedly. I hypothesize that we are going to continue to see that in Kenya, uniquely, the type of religion there is one of the drivers. So that then gives us an indication of where we can intervene, because religion is really important to so many people. So yes. It's about all those things, and it's complex, yes. And we're at time. This has been fantastic. And yes, I'll just say, someone had asked back in the beginning, isn't it all about social determinants? Yes, if we could, it is all about the social determinants. That is what is driving, that is what's driving stigma and discrimination and trauma, and then risk behaviors. And if we lived in a world that was kinder and affirming and accepting, we would not be seeing the kinds of things we're seeing today. I want to thank all of the panelists, and thanks to everyone who put this together. Fantastic job. So impressed with the conference, and look forward to the sessions that are coming up. Thank you so much.
And just want to add a plug. Thanks to all that answered the poll and for all the amazing work that you are doing in your communities.
Thank you.